This conference will now be recorded.
Good afternoon, everyone. Am I audible to you?
Yes, sir.
Am I audible?
Yes, sir.
Yes, sir.
Yesterday, which topic was done? Hypothyroid is finished, huh?
Yes, sir. Yesterday, hypothyroidism.
Okay. Okay, today we'll discuss about hyperthyroidism. See this case. A 32-year-old woman presents with fatigue and eye strain. She has been working as a secretary and noticed difficulty focusing her eyes. She said she was anxious and was having difficulty in writing. She reported that her sister was taking medication for thyroid problem. TSH was low and T4 levels were elevated. Her thyroid scan revealed enlarged thyroid with increased uptake. Okay. So this is the patient. There is no obvious swelling, but thyroid scan revealed this diffuse uptake. What is the diagnosis? What do you think of?
Thyrotoxicosis.
What is a better name for that? Graves' disease.
Graves' disease.
Yeah. So this is also similar case. A 37-year-old previously healthy woman presents to your clinic with unintentional weight loss. Over past 3 months, she has lost approximately 15 pounds without changing her diet and activity level. Otherwise, she was fine. She has an excellent appetite, no GI complaints except for occasional loose stools, good energy levels, and no complaint of fatigue. She denies heat or cold intolerance. On examination, heart rate is 108 and BP 142/82, and she is febrile. When she looks at you, she seems to stare and her eyes are somewhat protuberant. You note a large, smooth, non-tender thyroid gland and a 2/6 systolic ejection murmur on cardiac examination. And skin is warm and dry. So what is the most likely diagnosis? Similarly, it is the Graves' disease. So how will you confirm the diagnosis and what are the treatment options? Today our main topic is Graves' disease. Okay. So someone just now told thyrotoxicosis and the other word is hyperthyroidism. Is there any difference between these two terms? There is a small difference. Thyrotoxicosis is any excessive state of T3, T4, thyroid hormone excess is called thyrotoxicosis. In the name itself, it is there. Whereas hyperthyroidism is, it is a hypermetabolic condition, or it is a thyrotoxicosis due to excessive amount of thyroid hormones produced by the thyroid gland itself. If this thyrotoxicosis is due to excessive production of thyroid hormone by thyroid gland itself, then it is called hyperthyroidism. Okay. You see. So if the thyrotoxicosis is due to increased production of thyroid by thyroid gland, then it is hyperthyroidism. And there are other causes of thyrotoxicosis like excessive ingestion of thyroxine or release of hormone in ovarian tumors called struma ovary. Okay. All these are other causes of thyrotoxicosis other than hyperthyroidism. Okay. So today we'll discuss about it. So what are the causes of hyperthyroidism? So hyperthyroidism can be divided into primary and secondary hyperthyroidism. What is primary hyperthyroidism?
By the gland itself.
Hyperthyroidism is by the gland itself. Primary is problem lies within the thyroid gland, whereas secondary hyperthyroidism problem lies in the pituitary gland or some other area. Okay. And there are other causes like thyrotoxicosis without hyperthyroidism. Okay. So the main causes of primary hyperthyroidism, top three causes are Graves' disease, toxic MNG, toxic adenoma. These three are most common causes of primary hyperthyroidism. and other causes are there like struma ovary, iodine excess and all. Okay. So the goiter can be divided into clinical types: are diffuse toxic goiter, Graves' disease, toxic nodular goiter, toxic nodule, and hyperthyroidism due to other causes. Okay. So he is Robert James Graves. So he coined the term Graves' disease. Okay. So what is the salient feature of Graves' disease? The thyroid gland will be diffusely enlarged. You can see here the gland is diffusely enlarged. Okay. So diffusely enlarged thyroid gland is a salient feature of Graves' disease. Okay. So it is a diffuse vascular goiter commonly seen in younger women like 20 to 50 years of age group. The two cases you have seen at starting of this presentation, both are women and they are young age group. Okay. And there will be eye signs. You can see this is called thyroid associated ophthalmopathy or Graves ophthalmopathy. Okay. And it is a type of primary thyrotoxicosis, and there will be family history of autoimmune endocrine diseases. This is also important. Graves' disease is a type of autoimmune disease, so other associations will be there. Other autoimmune diseases will be associated. Okay. So the whole gland will be hypertrophied and hyperplasia and abnormal thyroid stimulating antibodies. Already we have I told that it is due to autoimmune cause. So autoimmune means there will be thyroid stimulating immunoglobulins, TSI, or thyroid stimulating antibodies. These antibodies will bind to the TSH receptor, and pathogenesis we'll discuss again. Okay. So there is a mnemonic. It is female, commonly seen in female with a family history of autoimmune diseases. E is extrathyroid manifestations that are like eye symptoms, and there will be thyroid dermopathy, acropathy. Other than thyroid, other organs also will be involved. Okay. Middle age is mostly involved. Autoimmune. Alpha HLA association will be there. It is associated with HLA DR. Okay. And E is enlargement of gland is diffuse. The diffuse enlargement will be seen. So if you remember this, you can write the whole essay. Okay. So this is the pathogenesis. As we have discussed, it is an autoimmune disease. So there will be thyroid stimulating immunoglobulins. You can see this is the antibody again, which will stimulate the TSH receptor. So normally, this is the thyroid gland. There are TSH receptors. Whenever pituitary secretes TSH hormone, that will stimulate the TSH receptor, and there will be production of thyroid hormones. But here, what will happen? These antibodies will be stimulating the TSH receptor, and there will be excessive production of the thyroid hormones because there won't be any feedback control also here. Okay. So this is a normal thyroid gland. Colloid filled follicles will be there. They will be lined by cuboidal epithelium. Okay. What are these cells in between? Parafollicular C cells. What do they secrete? Parafollicular C cells.
Calcitone.
Yeah, calcitone. Okay. So in Graves' disease, what will happen? There will be hypertrophy and hyperplasia, and there will be the cuboidal epithelium is converted to columnar epithelium. Okay. So what are the symptoms? You already know what are the symptoms of thyrotoxicosis. Hyperactivity, irritability, dysphoria, heat intolerance and sweating, palpitations, fatigue and weakness, weight loss with increased appetite. Patient will tell I'm having good appetite, but there will be weight loss. Okay. Diarrhea, polyuria, oligomenorrhea, loss of libido, and signs like tachycardia. AF will be seen. Tremor, goiter, warm and moist skin. Already you might have discussed about hypothyroidism, no, opposite, complete opposite. There can be lid retraction, gynecomastia. Okay. So these are the common kind of symptoms and signs for thyrotoxicosis. But for Graves' disease, there are specific symptoms. That is very important. Those are like ophthalmopathy and dermopathy. Okay. So this exophthalmos and all, and the skin involvement will be specific for Graves' disease. These all other symptoms are common for all hyperthyroidism, but only ophthalmopathy, dermopathy will be specific for Graves' disease. Okay, that is important. And there is some difference between primary and secondary hyperthyroidism. If it is a primary hyperthyroidism, symptoms are first and then there will be goiter. If it is secondary, there will be goiter and then the symptoms will come. Okay. So cardiac rhythm will be, tachycardia will be seen, and there are development of arrhythmias. Okay, and this is the stage of development of arrhythmias. Initially, the patient will have multiple extrasystoles. Okay, then it will convert to paroxysmal atrial tachycardia, and finally it will go to paroxysmal AF and persistent AF. Okay, the ultimate outcome will be AF if we don't treat the thyrotoxicosis. This sinus tachycardia will go to extrasystoles and then paroxysmal AT, then paroxysmal AF, and then persistent AF. Okay. And there can be myopathy, weakness of the proximal limb muscles. This is called thyrotoxic myopathy. Will you see myopathy in hypothyroidism? Hypothyroidism, myopathy will be there or not? Yes or no?
Yes, sir.
Which type of myopathy will be there? Proximal or distal?
Distal.
No. All endocrine related myopathies will be proximal only. Okay. Even hypothyroidism will have proximal myopathy. Okay. And hyperthyroidism also have proximal myopathy. It's not opposite. So these are the eye signs. You can see proptosis of the eye. There is periorbital edema. You can see here. Okay. So I told some signs are specific for Graves' disease. You can see these three features: ophthalmopathy, and this is thyroid dermopathy, and the other one is thyroid acropathy. Acrum means distal area. So the distal part of the fingers will be swollen. So this is thyroid acropathy. There will be clubbing. So first specific point is, already we have discussed, there is a diffuse painless enlargement of the thyroid gland. And ophthalmopathy you might have studied in ophthalmology, the no specs classification. This is no signs or symptoms, only signs, no symptoms. Then it will be soft tissue involvement. Both symptoms and signs will be present. P for proptosis and E for extraocular muscle involvement. C is corneal involvement, and ultimately there will be sight loss due to optic nerve involvement. How thyroid can lead to blindness? Can hyperthyroidism lead to blindness? What will be the mechanism?
Optic neuritis.
It's not neuritis specifically. This all the extraorbital muscles will be swollen now in Graves' disease. Due to that edema, the optic nerve will be compressed from outside. So due to optic nerve compression, there will be blindness ultimately. Okay. It is not due to the involvement of optic nerve per se, but due to compression of the optic nerve. So there are some named signs in goiter. This you have to remember. They may ask you in Viva. Surgery also it is important, no? Stellwag sign is absence of normal blinking. That is a staring look will be there. Von Graffe sign is upper eyelid lags behind the eyeball. So Darlimple sign is upper sclera is visible due to retraction of the upper eyelid. Normally, only the lower sclera is visible. Geoffroy sign is absence of wrinkling in the forehead on looking upwards with the face inclined downwards. Mobius sign is the medial rectus will be involved, so there will be failure to converge the eyeballs. Convergence will be lost. Okay. Gifford sign is difficulty in eversion of the upper eyelid. So these are some of the named signs in Graves' disease. And third is thyroid dermopathy. The other name is pretibial myxedema. Okay. Pretibial myxedema. It is due to thyroid hormone excess. There will be excessive secretion of the cytokines like interleukin 6 and all. Due to excessive secretion of cytokines, there will be glycosaminoglycan accumulation in the skin. What will happen if there is glycosaminoglycan accumulation? There will be water will be retained in the skin, so there will be non-pitting edema. So one of the causes of non-pitting edema will be pretibial myxedema. Okay, very important point. This is also called orange skin because the skin will be similar to the orange skin, orange. Okay, it is usually bilateral. And the fourth one specific to Graves is thyroid acropathy, that is clubbing of the fingers. So the endocrine causes of clubbing they may ask you in Viva. So Graves' disease is one of the endocrine causes of the clubbing. Okay. So now how will you diagnose? So this is the algorithm. So initially when you are suspecting thyroid problem, what will you do initially? TSH and T3, T4 levels. If the TSH is low and T4 is high, that is our case. It is primary thyroid toxicosis. If there are features of Graves' disease, then it will be Graves' disease. You treat for Graves' disease. If there are no features of Graves' disease, then it can be either multinodular goiter or toxic adenoma. Okay, how do you know whether it is multinodular goiter or toxic adenoma? You do a radionuclide scan. If the radionuclide uptake is nodular, then it is multinodular. If it is single uptake is there, then it is toxic adenoma. Okay. So there are other types. If TSH is normal or increased and T4 is high, then it will be due to pituitary adenoma, as we have discussed already. Okay. And there are other things like if TSH will be low and T4 will be normal, but patient will be having symptoms, then you go for T3 levels. So if T4 is normal and only T3 is high, then it is called T3 toxicosis. This is a rare case, or it can be due to subclinical hyperthyroidism. You can do follow-up in 6 to 12 weeks. So you have to do general examination, look for the goiter, and you have to look for the signs of hyperthyroidism. Blood test you have to order TSH, T4, T3. TSH will be low, T4, T3 will be elevated, and you can look for thyroid antibodies like thyroid stimulating immunoglobulin, anti-thyroid peroxidase, and anti-thyroglobulin. Okay, these antibodies will be present in 80% of the Graves' disease patients. Okay, these are non-specific laboratory findings like low serum total cholesterol, normochromic normocytic anemia, ALP will be elevated. This is not important. Okay. When do you go for a scan? If the clinically you can find that there is a diffuse goiter, there is no need of any nucleotide scan. You need radionuclide scan only if there is a confusion whether the patient is having Graves' disease or multinodular goiter. Okay, so you can see this is the image of Graves' disease. There is a diffuse uptake of tracer, radionuclide tracer in the Graves' disease, whereas in multinodular goiter it will be nodular uptake is there. Okay. So how do you treat this? So we have multiple treatment options, like we have pharmacotherapy, and we can give radioiodine therapy, and you can go for surgery. So these three are the options for treating hyperthyroidism. So pharmacotherapy includes anti-thyroid drugs and beta blockers, and radioactive therapy is with iodine 131, and you can go for surgery. Okay. So which treatment, which patient we have to give, that is also important. So the choice of therapy depends on the type of thyrotoxicosis, whether it is primary or not. If it is a multinodular goiter, what should we do? If it is a toxic adenoma, the treatment will be different. So it depends on the type of thyrotoxicosis and the age of the patient. If the patient is very high age is above 60 or something, then surgery is not a good choice. Then you go for radioiodine therapy. If there is coexisting medical illness and patient is not fit for surgery, then also you go for radioiodine therapy. Severity of thyrotoxicosis, that is also one of the deciding factors for choosing the which type of treatment we should give. Goiter size, if the patient is having a huge goiter and patient is having compression symptoms like dysphagia, dyspnea and all, what should we do? Then we should go for surgery. Okay. And presence of ophthalmopathy, one important thing is if you go for radioiodine therapy, the ophthalmopathy can aggravate. That is the point. So whenever you are giving radioiodine therapy, you should have a caution towards the ophthalmopathy. If there is coexisting ophthalmopathy, there is a chance that the ophthalmopathy can aggravate after the radio ablation. Okay. And another thing is patient preference. So considering all these factors, you have to pick one of the treatment choices for each patient, individualized therapy. Okay. So what are the anti-thyroid drugs, you know? Name some anti-thyroid drugs.
Carbimazole, methimazole, and propylthiouracil. Carbimazole,
Propylthiouracil. Yeah.
propylthiouracil.
Methimazole. So the most commonly used drug is methimazole and carbimazole. Okay. So what are the indications for anti-thyroid drugs? So if the patient is having high likelihood of remission, in the elderly patients, already we discussed, elderly patients also you go for drug treatment because surgery is not feasible. Pregnant women, pregnant ladies, radio ablation is contraindicated, absolutely contraindicated. So you should go for drug therapy. And if it is a Graves ophthalmopathy, I told you, if you give radioiodine ablation, then Graves ophthalmopathy can aggravate. So you go for drug therapy. And even though you are considering surgery, you should make the patient euthyroid before going for surgery. Otherwise, there will be a problem called, what problem will be there? Without controlling, if we do surgery, if we go for thyroidectomy,
Thyroid storm.
yeah, thyroid storm will be there. So you have to pre-treat the patient with anti-thyroid drugs. Okay. And soon after the radioactive therapy also, you have to give anti-thyroid drugs. So already she have told, these are the anti-thyroid drugs: carbimazole, propylthiouracil, and methimazole. And additional drugs like beta-adrenergic blockers, propranolol and nadolol can be given. Okay. And there are iodides. They decrease the vascularity of the thyroid gland, and they are used only as immediate preoperative measure. Okay. Like in thyroid storm, it is an emergency drug. Okay. So there are two regimens are there. Commonly used drug, I told you, carbimazole. You should start with 10 mg 3 or 4 times a day, and immediately there will not be any effect. It takes 2 weeks for the effect to appear once you start the anti-thyroid drugs. Okay. Once the patient becomes euthyroid, you can decrease the dose to 5 mg. Okay. Later you can reduce the dose slowly. And there is an alternative regimen called block and replacement therapy. Here you will give high doses of carbimazole so that there is zero production of thyroid hormones. So if there is no production of thyroid hormone, that is also a problem. Patient will go to hypothyroid. So you should supplement the thyroxine. This is called block and replace therapy. Here you are going step by step. Slowly you are starting and then you are tapering. This is one regimen. This is most commonly used. The other type of regimen is block and replace therapy. That is, you will give high dose of carbimazole and you will completely stop the production of thyroid. Then you have to supplement with thyroxine. Okay. So how long you will give anti-thyroid drugs? So the symptoms will improve in 2 weeks and patient will become euthyroid in about 6 weeks after starting the drugs. So you have to check the TSH and T3, T4 values. Don't repeat it every week or every 2 weeks. You have to repeat it for every 6 weeks. Okay. There is no point in repeating very frequently. So in Graves' disease, remission will be seen after 12 to 18 months. So every 3 months you can monitor, and then annually also you can monitor. Okay. But the problem with anti-thyroid drugs is once you stop the drugs, there may be recurrence. 40% patients will have recurrence in 1 year of stopping the drug. Okay. And multinodular goiter and toxic adenoma will not get cured by anti-thyroid drugs. Only surgery can be done in those patients. Okay. So what are the other drugs? Adjuvants are beta blockers. Propanolol. They inhibit the adrenergic effects. So all hyperthyroid patients will have adrenergic overactivity. So they will have tachycardia, sweating and all, anxiety. These are all due to adrenergic hyperactivity. So you can give beta blockers. So indications are prompt control of symptoms and treatment of choice for thyroiditis. Okay. And before surgery, if you want to reduce the risk of thyrotoxic crisis, you have to give beta blockers. Okay. What are the contraindications for beta blocker? Common contraindications, you know. Which patients you will not give beta blocker?
Bronchial asthma.
Bronchial asthma. Yeah. So whenever the older patients with bronchial asthma or pre-existing heart disease, you should cautiously give these drugs. Okay. The dose will be propranolol 20 to 40 mg 4 times a day. Okay. And you can give iodide, potassium iodide. So what is the action of iodide? It will block the conversion of T4 to T3 and inhibit hormone release. Okay. So the indications are similar to the beta blockers, like preoperatively and to reduce the gland vascularity before surgery and during pregnancy. Also we can give. Okay. So pregnancy, what is the important thing? What is the drug of choice in pregnancy? A pregnant lady comes to you with thyrotoxicosis or hyperthyroidism. What will you do? Any idea? Which drug will you give? So here you can see these are the drugs you can give, no? Carbimazole or propylthiouracil. So if you are giving carbimazole, there are side effects. In pregnancy, they can cross the placenta. Carbimazole, methimazole can cross the placenta, and what they will do? If they cross the placenta, they will cause neonatal hypothyroidism. So you should not give carbimazole or methimazole in first trimester. And also the other problem is they are teratogenic. So carbimazole and methimazole are contraindicated in first trimester. So first trimester the drug will be propylthiouracil. Okay. PTU should be given. And later you can change to other drugs. What is the problem with propylthiouracil? Why it is not being used? What is the main side effect with propylthiouracil? You might have read in pharmacology. The main problem is hepatotoxicity. Okay. So that is the reason why we are not using propylthiouracil. Other problem with propylthiouracil is it is a short acting drug. The effect is very short acting for 90 minutes only T half. So after that again we have to supplement. So multiple dosing should be given. Carbimazole is long acting drug. The effect will last for 24 to 48 hours. So propylthiouracil is usually not used. Only indication will be first trimester of pregnancy, and other indication is thyrotoxic crisis. Okay, these are the two indications for propylthiouracil. All other cases you use carbimazole or methimazole. Okay, this is very important point. Okay, and the definitive treatment is most cases the treatment of choice will be radionuclide therapy or radioiodine therapy. So here, what is the advantage of radioiodine therapy? There is no need for surgery, and there will not be any complications. Post-op hospitalization will not be there. Patient can need not take any drugs. Okay. So what is the specialty with radioactive iodine? This iodine will concentrate in the thyroid gland and destroys the thyroid tissue from inside. Okay. There is a cure rate will be very high, and it is a single dose treatment. 80% of the patients, only one radioiodine therapy will be enough. Okay. So it is a treatment of choice for Graves' disease, multinodular goiter, and recurrent thyrotoxicosis. Okay. It is effective, safe, and does not require hospitalization. It is given orally as a single dose in a capsule or liquid form. Okay. So what are the drawbacks here? The recovery time will be delayed. It will take around 6 to 8 weeks for the results to appear. And post-treatment, what will happen? All the thyroid tissue will be destroyed. So the patient will go into hypothyroidism. Okay. And as we have discussed, pregnancy it is absolutely contraindicated. Okay. And there can be neck soreness and all. And already we have discussed, it may exacerbate Graves' ophthalmopathy. Okay. These are the drawbacks with radioiodine therapy. So the last resort is surgical treatment. So surgical treatment is reserved for the patients who prefer to go for it, or pregnant women who cannot tolerate antithyroid drugs, or children and adolescent age group, large goiter with compressive symptoms, or severe Graves' ophthalmopathy, and the presence of suspicious nodules. These are the indications for going for surgery. Okay. So what surgery you will prefer? Near total or total thyroidectomy. Okay. So thyrotoxic crisis. This is also a short note for you. So what is thyrotoxic crisis? It is a life-threatening exacerbation of hyperthyroidism. What will happen? How will the patient present? He will present with fever, delirium, seizures, coma, vomiting, diarrhea, and jaundice. Okay. And mortality rate will be, even with treatment, it is 30%. So what are the causes of mortality here? It may be due to cardiac failure, or due to arrhythmias, or hyperthermia. These three are the common causes for death in thyrotoxic crisis. So which patients will have this? So there should be, already the patient should be suffering with hyperthyroidism, and there will be a precipitating factor like infection, stroke, diabetic ketoacidosis, or thyroid surgery. So with any of these precipitating factors on underlying hyperthyroid patient, it may trigger thyrotoxic crisis. So how do you manage thyrotoxic crisis? What is the drug of choice? Anyone? What is the antithyroid drug of choice here?
Propranolol.
Drug will be propylthiouracil should be given. Okay. I told you propylthiouracil is short acting drug, and the effect will be very fast compared to carbimazole. So whenever propylthiouracil is available, you should give 500 to 1000 milligrams of propylthiouracil either orally, or if the patient is in coma, you should give by Ryle's tube. Okay, this is the drug of choice. Then if it is not available, then you go for methimazole. After giving propylthiouracil, you can give iodide. You know already Wolff-Chaikoff effect and Jod-based phenomenon. You know, so iodide will work through Wolff-Chaikoff effect. Okay. and beta blocker should be given for reducing the adrenergic symptoms. And you can also give steroids. Hydrocortisone can be given. Okay. So the main treatment is propylthiouracil. So only two indications for propylthiouracil. One is thyrotoxic crisis and other is first trimester of the pregnancy. Okay. These two you remember enough. So what are the other causes of hyperthyroidism? Thyrotoxicosis factitia. What is it? What is thyrotoxicosis factitia? So the patient will be taking levothyroxine continuously. Some hypothyroid patient is there. You gave her thyroxine tablets, but she is taking excessive tablets, or you tell her to take one tablet and she will be taking 2-3 tablets. So she will end up in hyperthyroidism. That is called thyrotoxicosis factitia. Okay, or jod-based thyrotoxicosis due to iodine. Okay, and there are subacute forms or acute forms of autoimmune thyroiditis. It is called dequeverance thyroiditis. Subacute thyroiditis is also called dequeverant thyroiditis, and maybe due to secondary carcinoma or neonatal thyrotoxicosis. Okay, so the other causes, main causes, acute thyroiditis, subacute thyroiditis, and chronic thyroiditis. Acute thyroiditis, acute is caused by either bacteria or fungi, any infection. So acute thyroiditis is caused by bacterial infection like staphylococcus, streptococcus, or enterobacter, and fungal infection like pneumocystis, aspergillus, candida, and all. And subacute like viral. Viral will be subacute, mumps, measles, and all. And it can be mycobacterial infection. TB also can cause subacute thyroiditis, or it can be due to drug induced, like amiodarone, interferon, and all. Okay. Chronic thyroiditis is due to Hashimoto's thyroiditis, atrophic thyroiditis, and Riddle's thyroiditis. Okay. So this is the clinical course of subacute thyroiditis. What will happen here? Initially, here what is the problem? Pathogenesis will be the thyroid gland will be destroyed initially. So during initial phase of destruction, what will happen? Due to inflammation, all the thyroid hormones will be released into the circulation. So initial phase will be thyrotoxic phase, because the gland is being destroyed, and whatever thyroglobulin is present in the within the gland, it is released into the blood. So there will be thyrotoxic phase initially, followed by, after complete destruction, what will happen? He will end up in hypothyroid, then again recovery. So these phases will be there in subacute thyroiditis. Initial thyrotoxic phase, followed by hypothyroid, followed by recovery. Okay, if you see this three different phases, then you think of thyroiditis. And other clinical symptom will be pain. Graves' disease is painless enlargement of thyroid gland. No, here it is painful. Okay. So how do you treat? You give aspirin or other NSAIDs, and you can go for steroids. Okay. The other causes like toxic nodular goiter, also called plumber's disease. If it is present for long duration, middle age or elderly, eye symptoms will not be present, and it is called secondary thyrotoxicosis. Okay. Toxic nodular adenoma can be seen. Okay, thank you. Any doubts? Shall we stop the class?
Yes,
Yes,
sir.
sir.
Okay, thank you.